I think we can start now. Rakhi, you can start your presentation.
Good morning, everyone. Here I am presenting Miltefosine related keratitis, clinical characteristics and management. I have no financial interest in the subject matter. Miltefosine, a phosphocholine analog that is originally developed as anti-malignant drug, and it has been recommended by WHO to treat all types of leishmaniasis since 2002. And since then, it is first and is still the only oral drug that can be used to treat Kala Azar and its dermal sequelae, that is dermal leishmaniasis. Kala Azar, as we all know, it's caused by Leishmania donovani, and in 10 to 20% of successfully cured cases, the patients develop post-Kala Azar dermal leishmaniasis, which is a potential source of Leishmania infection, and it is characterized by skin rashes. In Bihar, its prevalence is ranging from 4.4 to 7.8 per thousand population in Bihar. The recommended doses of Miltefosine for PKDL is 100 milligrams per day for 84 days with very minimal adverse reactions like gastrointestinal symptoms. However, there are recent reports documenting the serious corneal complications in patients receiving Miltefosine. Although these reports have highlighted the corneal complication, the clinical impression of this entity varied in all the reports from Murren's ulcer to scleritis, and little is known about its clinical course and management. So in this study, we describe the diagnostic clinical features, progression and management of Miltefosine related keratitis in 6 patients. This study was done retrospectively from April 2018 to December 2021, including 6 PKDL patients receiving Miltefosine, and this study was approved by IEC and written informed consent was obtained. The evaluation included complete medical history focusing on the drug used to treat Kala Azar and PKDL, and documentation of dose and duration of treatment, and the onset of keratitis after initiation of drug was documented. We also performed the casualty assessment of ADR to Miltefosine by WHO UMC criteria. All keratitis were worked up, including size, location, pattern, extent and depth of the infiltrates, presence or absence of hypopyon and epithelial defect, including edema and corneal thinning. And all corneal specimens were subjected for the direct smear examination and culture, and PCR was done to rule out Leishmania donovani in the corneal scrapings. RK39 and skin biopsy was done in all the patients to confirm the diagnosis of PKDL. Results of all 6 patients, the case 1 was bilateral keratitis. He was receiving Miltefosine for 48 days and he continued taking this drug for another 17 days after appearance of ocular complaints. On the day of presentation, the picture was, there was a paralimbal full thickness infiltrate in both the eyes with hypopyon, and we suspected an infective organism since we were not aware of the manifestation of this drug. So we started fortified antibiotic, and still after starting antibiotics, the patient, the ulcer was progressing very rapidly, involving the center and resulting the corneal thinning, for which patient had to undergone for the PK. And left eye, and since the microbiological reports came negative, we started steroid, oral and topical, and patient left eye responded very well with 6/12 vision. In the second patient, the case was again bilateral keratitis, Miltefosine for 35 days, and he continued medication for another 20 days after appearance of ocular complaints. And the picture was very classical. The ring infiltrate the full thickness ring infiltrate rapidly extending to the center as well as circumferentially, for which right eye was operated for PK, and left eye responded very well to oral steroid and topical with 6/9 vision. Next 4 cases out of 6 were unilateral keratitis, and they were also taking Miltefosine from 38 days to 65 days. And one thing was common in all, that they just stopped the Miltefosine after appearance of ocular symptom, and they responded very well to topical steroid with good vision. So results, ocular symptom were pain, watering, photophobia, keratitis, ring shape, full thickness, paralimbal infiltrate. 2 cases were bilateral and 4 unilateral. Laboratory test shows positivity only on RK39 and skin biopsy test. Management discontinuation of drug and initiation of corticosteroid, and WHO UMC criteria showed the probable association between ADR and Miltefosine in all the patient. So we found a consistent pattern of keratitis and its course in all the patients receiving Miltefosine, and on the basis of our results, we could divide this entity into 2 stages. Early stage where the ring infiltrate were present, and there was an intervening clear zone between limbus and the lesion, and at advanced stages the infiltrates extended to the cornea as well as the circumferentially, leading to a ulcerative keratitis appearance. Mechanism of keratitis is not very clear. It has been documented that the drug might be directly toxic to the ocular tissues, and management is stopping the Miltefosine, excluding the infectious etiology, initiating the early anti-inflammatory therapy, and deferring PK in a complicated cases. So in conclusion, this study indicates a prolonged use of Miltefosine might cause keratitis, and early diagnosis with discontinuation and initiation of corticosteroid are key to successful management. And this study also emphasized the need to strengthen the pharmacovigilance program in endemic areas, and patients who are receiving Miltefosine should undergo periodic ocular examination by an ophthalmologist. These are the references. Thank you.
Thank you very much for your presentation. Who's going to discuss? Dr. Grover, sir.
How does the description or the observations differ from the previously available literature on this?
So there are 4 reports already have been they are documented, and in all the cases, first case reported that the lesion is just focal in the superior temporal quadrant. Another study documented it as a Murren's ulcer. Next to study from the Bangladesh.
Are those case reports or are they number of
cases? They were
cases?
case series basically. They were case series. All were case series.
The question that I have for you is, first of all, congrats to making it to the finals and a very nicely collated presentation.
Thank you, ma'am.
So, since you postulated that it could be direct drug toxicity or immune mediated, as shown by the peripheral nature of the problem, did you investigate these patients to rule out any underlying autoimmune disease as well, which Miltefosine has potentiated, number 1? And number 2, if it has behaved like Murren's ulcer, I see in most of your patients the central cornea was spared. So while doing the surgery, why did you opt for a PKP? Why did you not do a patch graft or an annular graft in these cases and save the central cornea?
What was the first question, pardon?
My first question was, did you investigate them for any underlying immune disease which Miltefosine might have potentiated?
We examined all the patients. Systemic examination was done, and all patients were immunocompetent without any concomitant systemic illnesses. And it was also examined by the medicine people.
So that should have been mentioned in your presentation because it is a very relevant point.
Yes, okay. And the second question is, in first patient who presented to bilateral keratitis, the central cornea was also thinned out during the progression of ulcer. It was so rapidly extending. So that's why we chose PK in the first eye. And in the second eye, the peripheral cornea was very thin, and it involves the whole 360-degree part of cornea, and that's why we choose to do PK, because we were not aware of this condition, like steroid is very good for these patients.
Thank you very much. Professor Dityal?
Thank you, Rakhi. Looking into this, ocular complication coming up, would there be some sort of prophylaxis and treatment for these people to prevent this happening? As Dr. Radhika talked about, if we can pick up some sort of immunological process happening, so should we give them some other treatment like a steroid to begin with the treatment?
As we followed up this patient for so long, and we found that this keratitis appears only after 1 month. Taking the average of all the previous study and our study also, the average is coming 30 to 42 days. In our study, it is 48. So after 1 month, they need a good examination by ophthalmologist, as well as if the drug has to continue for this entity dermal leishmaniasis, then we can start a low dose steroid under supervision and IOP monitoring.
I think that should be the way forward, because you have such a high incidence, so we have to look for this prophylaxis also.
Yes.
Thank you, Rakhi. Wish you all the best.
Thank you so much, sir.